Welcome to a special edition of the Bioethics Channel as we take a look at healthcare reform moving forward following the ruling by the U.S. Supreme Court on June 28, 2012. Joining us now from New York is Dr. Joseph Finns, who among many titles is the Director of Medical Ethics at New York Presbyterian Weill Cornell Medical Center. Dr. Finns, it's been a few weeks now since the Supreme Court decision allowing this act to move forward. Do we really know yet how this law will affect doctors and patients in terms of access and making medical decisions?
Well, I think it's welcome news from my point of view. I think it'll improve access to care. I think it's long overdue, and many patients and families are going to be really helped by this increased access to care. I still think that the rollout is going to be complicated and contentious, especially about the Medicaid buy-in or buy-out from particular states. So there may be a bit of a patchwork in implementation around the country. My concerns, are not with the bill writ large, but how it might affect particular populations. And we could talk some more about that if you'd like.
So what about the populations that you're most concerned with? Talk about that a little bit, if you would.
Yes, I'm concerned about patients with very severe brain injury and what we call disorders of consciousness. Patients who are recovering from brain injury or aneurysms or stroke who end up in what we describe as the minimally conscious state. And one of my great concerns is that so much of this legislation, this law, is predicated upon notions of efficiency of care and ensuring that we don't waste medical resources. And I'm all in favor of that. But the challenge is it's hard to know what efficient care is when we don't necessarily know the timeline against which people are supposed to recover. And there's nowhere where that question is more sort of operative than in the recovery from severe brain injury. And I'm very concerned, that people are not going to be given the opportunity to get better and given the amount of care that they need over time, given the nod towards efficiency that this law is really predicated upon. One of the interesting features of the Accountable Care Act was that rehabilitation was not initially a part of one of the key principles in the legislation, and that was added later on. And so it's really important that we have an awareness that some populations are going to be perhaps disadvantaged by this. Now, on the other hand, some of the really good aspects of the bill is that it increases Medicaid eligibility above the federal poverty level. It gives tax credits for people who are somewhat above the federal poverty level. It allows dependent coverage to 26-year-old and below patients. So, young people who are, the leading population for brain injury in that age category will be covered. It does provide affordable coverage for pre-existing conditions, but it's unclear, how that will play out when there are reviews of particular individuals, and there are increased consumer protections and coverage. So I think what's going to happen is we're going to have a tension between an ethical and procedural tension between, on the one hand, incentive-based performance metrics for diseases whose trajectories we understand, versus the still uncharted path of recovery for brain injury. And it's going to be, will the protections protect you, or will the efficiencies get you? And for those who are listening who are perhaps not as familiar with the legislation as some of the people who were writing it or thinking about it, these efficiencies that I'm worried about could be what we call medical necessity on steroids. Medical necessity is the way that we now currently provide care to patients, and if you don't demonstrate overt recovery, we don't pay for care. And what happens with brain injury is there may not be behavioral evidence of recovery, even even though the brain itself in the inside is actually recovering. And until you demonstrate the recovery, you may lose your eligibility.
So what if I'm hearing you correctly, you have some tough cases, brain injury being one of them, but whenever we get into the realm of tough cases, we're going to be left with sorting a lot of things out when it comes to this new law. Am I hearing you correctly on that?
Right. I mean, I think it's this I think could be the poster child case for this particular weakness. I think in the law. Typically people get 8-week periods to rehabilitate, 6 to 8 week periods. So that may be too short to demonstrate improvement, and the clock is always ticking. And I think the clock is going to be ticking louder with this legislation. And we have to remember that brains recover by biological criteria, not by reimbursement criteria. And that's going to be true for any disease where we don't know much about it. In which cases, we don't have the timeline, we don't know what the time grid is, and we don't know what appropriate length of care, should be. So I think we'd be very, judicious about implementing guidelines without mechanisms to question whether or not they're being appropriately applied. It's one thing if you fracture your hip and you get, a hip replacement and you get hip rehabilitation and physical therapy, and you go a certain number of paces. At a certain point, it's clear that you can continue on with your rehabilitation in a less, say, intensive setting. But the brain is much more cryptic about the timeline. So that's my major concern.
Now, you're a medical educator as well, and what this bill calls for is for more people to be insured, and that means that we need more doctors, correct? And
Absolutely.
How are we doing in that regard?
Well, the pipeline needs to be filled up a bit, and we probably also need to reallocate, the percentage of people who are going into primary care. All that is terrific. But my other concern, if you allow me to have two concerns,
sure, go ahead,
is what this all means for academic medical centers. We know, and there have been a number of distinguished policy people and economists who've written about this, that academic medical centers will receive less funding under the Accountable Care Act. That, coupled with decreased NIH funding, really poses a threat to academic medicine as we know it, and I'm very concerned that institutions which took a century to get put together, could really be deconstructed and harmed, in the short term by inadequate funding. We doubled the NIH budget in the 90s, and it's down probably 20% in real dollars since the peak. Which means you've created a whole cohort of young investigators through training programs in the doubling phase, and now they're left unable to find meaningful work, or have to wait till their late 40s till their first R01 is funded. And I think the academic medical centers and academic medical infrastructure that we've created in the United States, as flawed as it is, and not providing universal care, which is being remedied, shouldn't be sacrificed at the altar of access. I think we should have innovation and access, discovery and access, and I think it's important that we have a balanced approach. And even as we increase slots, laudably increase slots in primary care, we shouldn't forget physician investigators and those who move the ball forward in what we know and what we can provide. I mean, it's absolutely, really just untenable that investigators, the best of the very best, are getting funded at the NIH, at the 10%. It used to be the top 25th first quartile people got funded. And as Paul Nurse, the former president of Rockefeller University, once said, once you're in the top quartile, you can't distinguish, one from the other, and yet that's what's happening, and it creates makes it kind of an issue of chance about whether or not people get funded. So I really think that we have to appreciate that we probably are overspending in general for healthcare relative to our economy, but we have to make sure that we spend wisely and make sure that we're paying for current needs and also ensuring future progress by funding the medical infrastructure and the academic side of the equation, which does cost more. It costs more money to train medical students and the like. Although interestingly, there have been other studies that show that good academic medical centers actually cost less. Herb Partis pointed this out in a piece in the Atlantic recently, that academic medical centers providing appropriate care, actually evidence-based care, actually costs less in some circumstances than what you might receive at a community hospital.
So, Dr. Fins, considering your concerns, would it be fair to say that we should be hopeful that we could be nimble and flexible with the implementation of this law, considering that some of these concerns that you're expressing will make themselves apparent in some cases very quickly?
Yeah, I think. Look, we are so much better off with this law than without this law, and I think President Obama, has achieved a historic milestone, and I think Chief Justice Roberts is going to go down in history, for having the courage to uphold, the law, along with the other four justices who voted with him. And I think we have to be nimble. I mean, the alternative that we had before was indecision, real confusion about what the future would hold. At least now we know what the problems are, and we can begin to be strategic and responsive instead of speculating about a system that we didn't know what it would be, and now we know at least the structure of what we have to contend with.
It seems that we've been moving back and forth on a spectrum for a long time, where we've looked at the one side of things with it being completely market-driven healthcare, where I think we've been uncomfortable because you have winners and losers on that side of the spectrum. And then the other side of it is government healthcare, where we have a discomfort over government being in charge. Are we getting closer to identifying a sweet spot, I guess, the moral place where we need to be on that spectrum?
I don't want to demonize government or the private sector. I think the beauty of our economy is that America works best when these sectors work together, and that's the way it's always been. I think if anything, the government sector has been underrepresented, and there's been too much marketplace in the healthcare sector, and I think that needs to be remedied. I think one of the challenges you mentioned earlier, the question of education, there's a latency to one's investment in a student or in a university or in a laboratory that does not necessarily cohere with a quarterly approach of business. So we invest in a student today, and 25 years later, he discovers or she discovers a cure for HIV. Hopefully it'll happen long before that. But that investment is not recouped in the fiscal year. And so we have to have both a tactical approach, which is where business is much better, and we also have to have strategic vision, where good businesses are always there, but we have to invest in things that don't necessarily reap an immediate benefit, which is what shareholders often clamor for. Long term, we have to think about the future, and I think government is better positioned to think about building infrastructure that will reap benefits for the long term. And I think we're still using WPA post offices from the 30s, and they're still serving us well. And they were just an expenditure in the beginning, and now they're part of a worn-out infrastructure that needs to be replaced. But for 60, 70 years, they served us very, very well. And I think that these academic medical centers, need similar tending so that they can continue to provide benefit going forward. And I think the government has a role to play there, and cannot step out of that role because no one else will step in.
Dr. Joseph Fins is the Director of Medical Ethics at New York Presbyterian Weill Cornell Medical Center. I'm Lorell LaBoube. Thanks for listening to the Bioethics Channel.